Augmentation cystoplasty patients, they are the happiest people. There is data to support this. The Enbridge group, led by John Stoffel, did a very in-depth quality of life assessment of patients with neurogenic bladder, and they focused on spinal cord injury. And your reconstructed patients, by far the happiest. There was not even, it was leagues of difference. And that's because an augmentation cystoplasty gets you a reliable 800 cc bladder. And you know what that lets you do? Sleep through the night. That's awesome. Sleeping through the night is epic.
Hello and welcome to our WInnovations podcast. I'm your host, Dr. Kyle A. Richards, and we have a super exciting program planned for today. We're in season 3 of our podcast and thrilled to be back in the Department of Urology studios at the University of Wisconsin. I'm pleased to introduce our guests, Dr. Ann Cameron and Dr. Javier Santiago. Ann is the James Montie, MD, Legacy Professor of Urology at the University of Michigan and Vice Chair of Academic Affairs in the Department of Urology. She's a practicing urogynecologist and pelvic reconstructive surgeon and conducts federally funded clinical trials. Prior to arriving at Michigan, she completed her medical degree at the University of Ottawa and urology residency at Dalhousie University in Halifax. She is also a graduate of the prestigious AUA Leadership Program and currently serves as chair of the AUA Overactive Bladder Cancer Guidelines Committee, amongst many other roles. Ann, welcome to the program.
Hey, thanks, Kyle.
And Dr. Javier Santiago is one of our own here at UW, is an assistant professor of urology in our department here at the University of Wisconsin. He is a native Texan and joined faculty in 2024. He did his urology residency at the University of Michigan under the tutelage of Dr. Cameron, amongst others. And Javi then completed a genitourinary reconstructive and prosthetics fellowship at the Cleveland Clinic in 2024 with a focus on neurourology. And welcome to the program, Javi.
Thank you very much, Kyle.
And I know both of our guests are passionate about improving and innovating the care of patients with neurogenic urology issues. I certainly am eager to learn from them today as a simple urologic oncologist. I love learning from my guests. We're calling today's session Neurogenic Bladder, Nuances, New Approaches, and Next Level. So Ann, neurogenic bladder, and I think before we came on, you were actually educating me a little bit on neurogenic bladder already. The terminology has actually changed somewhat, but we oftentimes refer to the overall condition as neurogenic bladder. So maybe you could dive into sort of a little bit on the terminology. What is neurogenic bladder and what are some of the most common conditions that cause it? Because it can be a very heterogeneous group of disorders.
Yeah, thanks, Kyle. So the current terminology that is considered more precise is neurogenic lower urinary tract dysfunction. But you can see how long it took me to say that. So when I'm speaking and referring to it in conversation, I certainly revert back to our more familiar neurogenic bladder. And that's what we'll use today because it is so much easier. It rolls off the tongue a lot better. Neurogenic bladder is a condition where the bladder is affected by neurologic diseases. And the neurologic diseases that we always are associating with neurogenic bladder are things like spina bifida, multiple sclerosis, and spinal cord injury. And the reason that we associate those is because the frequency of neurogenic dysfunction in those patients is 80, 90, sometimes even 100%. So those are spinal cord lesions that cause very severe bladder conditions, usually urinary retention. But there are many neurologic conditions from the brain all the way down to the peripheral nerves where injury to the nerve in some way causes some effect on the bladder. So other examples are things like cauda equina or peripheral nerve injury from rectal surgery. But things like stroke and Parkinson's disease can also affect the bladder, but they do affect the bladder differently in that some result in balance voiding, meaning the person can urinate on their own and is not in retention. Those are more your brain lesions. And there are spinal cord down lesions that tend to cause urinary retention or atonic bladder. But one thing that is not neurogenic bladder is someone whose bladder just doesn't work. So many times a patient will have retention, no one knows why, and they get labeled as having neurogenic bladder just because their bladder doesn't work. You do have to have some kind of neurologic injury or condition that goes with the neurogenic bladder for that to be accurately labeled.
Thanks, Ann. That's a great summary. Javi, anything to add to that, or do you think about it any differently than Ann?
No, I think that was a great summary. And no, I think Ann kind of highlighted it. I mean, this is a big catch-all for a lot of different disease states. And within those disease states, patients can be quite heterogeneous. And so it ends up being a lot of just a very different sort of functional problems and maybe even safety problems that end up arising from these diseases. So it takes a very much like a personalized approach for each of these patients, even though we do kind of have some expectations of how certain folks with certain diseases are going to end up behaving. But no, that's a great summary.
I want to get into sort of, I like to sort of pick my guests' brains about sort of what drew them to their respective fields. So I'll start with you on this one, Javi. So what was it then about this field of neurogenic lower urinary tract dysfunction that got you interested and excited?
Yeah, I mean, other than a very stereotypical cheesy response of saying like I had some interest in neuroscience coming out of high school and college, thought it was mind blowing. But going into urology residency training, I think some of the things that I was most intrigued by were actually some of the things I just mentioned, in that it really required like a good understanding of where patients are coming from and where they would like to be in terms of coming up with good treatment plans. And I had the great benefit of having some excellent mentors and role models in terms of how to interact with patients and get to know them better and come up with thoughtful plans for them. People like Ann herself and Dr. Stoffel, John Stoffel at Michigan, and other folks. And but I think that was a major thing for me, is that it was a subfield in urology that allowed for a very deep connection with patients and like opportunities for lifelong care. Within that, a lot of really fascinating types of surgeries that can be offered for patients, even though not everybody needs big surgeries. But sometimes folks will need something a little bit more invasive and some creative solutions to their problems. So that was probably the most interesting thing. One other thing I liked about it is that there's just a lot of need in the country for it, and not a lot of people who are interested in it. And that part was also attractive in being able to maybe fill a niche that a lot of urologists are kind of steer clear of neurologic diseases. And so that was something I felt called to provide some of that care.
Hey, what about you, Ann? What drew you to the field?
So I had almost no exposure to neurourology as a resident, just because of the geographic location where I trained. And when I joined the fellowship at the University of Michigan, it was primarily with the intention of learning urogynecology and female urology. That was my original intent. But I spent significant amount of time with Ed McGuire as well as Quentin Clemens looking after this patient population. And I find them such an interesting group of people where you can have such a tremendous impact. The impact and the success of many of the treatments we do are so immediate. When you do a botulinum toxin injection on someone's bladder who has DO, they are going to get better. Like, it's not a question, I wonder if they're going to get better. They get better. You do an augment, they are going to get better. The slam dunk kind of therapies we have to offer these people are great. And again, to echo what Javi said, when you meet someone who has significant neurologic disease, they are confined to a wheelchair, may have a lot of mobility problems, and you have an office that's ADA accessible, you have a Hoyer lift in the ceiling, you have staff who know how to deal with autonomic dysreflexia, and you ask them about their skin and their bowels and their bowel program, and their jaw drops, and they're like, oh my goodness, you actually know about my medical care. They're so happy to meet someone who doesn't just treat their blood pressure or treat their one medical issue. It's like, sure, I'm going to treat your bladder issues, but I'm aware of all the other syndromes and issues that you have surrounding your injury. And they're so grateful. So I find it very rewarding to help this patient population, because I have patients that I started seeing as a fellow, and they're still coming back to see me on the regular. And it's not a small number either. They are, completely committed to coming back to see me because they are so happy with the care they're getting. And that's pretty rewarding.
It sounds like it, and that's great to hear. Now, it sounds also to me, Anne, like these are pretty challenging patients to manage. Can you speak to a little bit of the challenges and some of the barriers that these patients face?
Transportation is a huge one. These people arrange transportation with, either a set transportation service, or maybe they rely on family, or some do have their own vehicle that they can drive or have someone drive them. But it's not their fault if they don't show up to your appointment. They arrange transportation doesn't show up. You have to give them a lot of grace, and there's no malice in their no-show rate. So you just have to be understanding of that. If your office is not set up for this patient population, you're going to have a really bad day. I'm in a brand new office in Brighton that has, sliding pocket doors, tables that descend down to 12 inches off the floor, Hoyer lifts in most of our rooms. And again, we just have a setup that is so friendly to that patient population so that they are not impaired in any way. The rooms are big enough so that they can come in the room, turn around in their completely motorized wheelchair, and have their family members or caseworker with them without any difficulty. So it just makes the whole ambiance so much more friendly to them because they feel like you've already prepared for them to come. So that really makes a huge difference because that's not available everywhere.
And on the flip side, Javi, you're kind of getting started. Anne's been doing this for a little while, as we know, and doing a great job. But what are some of the challenges for you just getting started, building your own neurogenic practice here at University of Wisconsin?
I mean, first off, that was one thing in terms of trying to think, okay, where do I want to start a career and build a career? Having a place that has some infrastructure to be able to facilitate the things that Anne was talking about is huge. And I do feel happy to have the luxury of that as well. Yeah, I mean, other than a lot of things that Anne mentioned, I 100% agree with. I think one of the challenges in these group of patients is that, like a lot of areas of medicine, there's algorithmic care, and you have X problem, we have X solution. You have progress along. If this doesn't work, then we go to this. And I mean, for a lot of folks, certain therapies just are not going to be feasible, either because of their dexterity at home or the kind of care that they have on a day-to-day basis. As a quick example, I mean, we have an ideal of people using intermittent catheterization for managing their bladder, but just the reality is a lot of patients are not going to be able to do that. Or we have, certain things that we want them to do at home in terms of catheter care or in general care for them that just have to be worked around. And a lot of times it may be that, okay, yeah, we have this ideal, maybe we can't get there, but let's find something that works just good enough for you and keeps you out of the hospital and keeps you from having just a miserable day-to-day quality of life and get into something that's livable. So I think just continuing to find what are the backup plans for people based on the limitations of their social situations has been a good thing. So it requires a lot of flexibility too, like Anne mentioned, having a lot of grace, being like, okay, I get it. We're not going to be able to do this, but let's find a way that we can keep you safe.
Yeah, those are great points. Excellent. Now, I wanted to get into sort of some of the management of these patients, kind of going through some of the medical management, some of the diagnostic evaluation. And I think I wanted to start by sort of talking about medications that are used to manage these patients' bladders. And oftentimes, anticholinergics are medications that are used, as we all know. Are there any nuances in the use of these medications in this patient population? And then what about any sort of newer medications that have come down the pike? Because anticholinergics have been around for some time. Maybe I'll start with you, Javi, on this one.
Yeah, sure. And, this is another situation where we have certain things available, but there's just from either insurance coverage or just what's going to be feasible to get to patients, we have some limitations. So, broad class of anticholinergic medications, including the oxybutinins, the trospiums, the Detrol, all these work similarly in terms of doing what we want, in terms of getting the bladder to store urine at lower pressures and perhaps improve quality of life issues like urinary incontinence and perhaps protect their upper tracts by keeping their pressures lower. There's some things that we for sure keep in consideration. There's different side effect profiles for each of these medications. They variably impact constipation or dry mouth, a lot of things that are really significant for this patient population and can lead to to lead to more problems for them, particularly if they're already dealing with constipation and then you're loading them up with anticholinergics. It's making it worse, making not only their urinary symptoms worse, but then potentially, say, for instance, a spinal cord injury patient who's dealing with autonomic dysreflexia, you loading them up with anticholinergics, preserving their bladder, but all of a sudden now they have terrible constipation and they're having AD on, multiple times a day. So that's certainly a consideration. And there's a lot of practice variation in terms of what meds and what dosing are prescribed. I feel like I meet a lot of patients who are on very high doses, perhaps, particularly some congenital patients who have been on very high doses since they were young and have stayed on there. Some of those things, particularly as patients age, there are some concerns that a lot of the anticholinergics can cross the blood-brain barrier and potentially put patients at risk for cognitive changes, particularly over if they're using it for decades and decades and into advanced age. So that's something to keep in mind. There's medications like trospium, which do not cross the blood-brain barrier. I tend to try to utilize that as much as possible, though there may be patients who actually have worse side effects from that, despite the fact that there may be some degree of cognitive protection from that. So that's kind of that class of medications, and there's a lot of tweaking that can be done. Also, I don't do it super commonly, but some of these meds have different delivery mechanisms. Transdermal oxybutynin used to be a thing that it's not, I believe it's just not even made anymore, or not sold. But some people will instill oxybutynin into the bladder with some variable effect. Other options to try and protect people from the side effects of systemic use. I mean, there are other classes of medications. Actually, if I could give a shout out to Anne, she has a great paper from I think 2015, 2016 that goes through a lot of different medications that are used for neurogenic bladder. Definitely worth anybody who's listening who's interested checking that out. But just kind of focusing on the most common meds, we then have the class of beta-3 agonists, which are used both in overactive bladder as well as other conditions like in neurogenic bladder and have found to be effective. Generally, we're talking about mirabegron and vibegron, both of which are nearing perhaps generic development and hopefully decrease in cost. But these work through a completely separate pathway, through the adrenergic pathway, and to improve the storage capacity of the bladder. And these are also effective for this patient population. They can be used in combination therapy with anticholinergic meds to maximize the benefit. And then thankfully, they don't really have any of the side effects of the dry mouth, the constipation, potentially increasing their heart rate that anticholinergics can do. Really, the main side effect that is generally reported is a few point increase potentially in blood pressure, and we generally avoid those people. Avoid these in people who have very high resting blood pressures. But they can be challenging to get to patients. They tend to be, for a good portion of folks, quite expensive, and for some patients, either they can get it covered in a way that's reasonable or they're willing to pay that price. And so ends up being a good option. But there's other medications that have been classically used in neurogenic bladder, like imipramine and others that take a little bit more consideration of what the other effects are happening throughout the body and the brain. But yeah, and you may have some additional input on these meds and their use.
Yeah, so the anticholinergic class of medications are increasingly becoming poo-pooed in our world. There is pretty robust data that they cause dementia. It's not subtle data. It's not a small retrospective study. This is large population-based data. A lot of it's from Blaine Welk in Canada, where they have a single-payer healthcare system, so they're able to track medication and anticholinergic load. And people develop dementia while taking these medications. And I have a really hard time telling a newly spinal cord injured 25-year-old, here, why don't you take this medicine? It might cause dementia if you take it for a long time. And by the way, I'm prescribing this for life. So that, to me, that's, that I have a real hard time with that. And if you think about it practically, any medication that if taken in overdose impacts cognition is probably not good for you in lower doses every day. So if you overdose on ditropan, you do have acute cognitive impact. So taking a low dose of a brain toxin every day forever is just bad news. I also have really significant concerns about using these drugs in patients who have brain diseases. So people with stroke, your Parkinson's patient, your MS patient that may have some neurocognitive involvement, and also those people that are voiding, that are potentially on the cusp of urinary retention. You can flip them into retention. So if you really want to know how I feel about anticholinergics, that was it. The mirabegron is not even a new medication. Mirabegron was FDA approved in 2012. It's been around since then. It is a generic version. It does have the slight risk in elevation of blood pressure, but newer Vibegron does not carry that risk. And so there's very little nuance to using those medications in this patient population. In those people that I'm concerned about retention or tipping them into retention, I really push towards using the beta-3 agonist. And the AUA Neurogenic lower urinary tract dysfunction guideline in one of their statements said that anticholinergics or beta-3 agonists can be used as oral agents to control detrusor overactivity. So they put them in the same statement because as a group, we really thought that this was important to state. So there's not been a lot on the cognitive impact in this specific patient population, but I don't see why they'd be at any less risk than the general population of cognitive decline. So if I can avoid it, I don't use them.
Are there any new meds coming down the pipeline, Anne?
No.
Yeah, I'm also not aware. I'm not exactly sure what the exact status of it is, but some interesting work being done in terms of gene therapy and delivery of intravesical medications. That may provide some of the similar benefits that we're getting from those medications, but just a totally novel pathway that helps protect patients from some of the side effects of these meds. Stuff that gene therapy that's either utilizing some of the mechanism of Botox or affecting different channels that are responsible for contractility in the bladder, but I'm not sure exactly how far those things are out, but around the corner.
Yeah, again, those are all still investigational, but there's certainly been also a lot of new developments in UTI prevention in this patient population. There are companies pursuing indwelling bladder widgets that deliver antibiotics for the recurrent UTI population who can't get rid of their UTIs, rather than doing daily gentamicin installations, which is something that I use all the time for those patients who have UTIs that don't respond to, normal hygiene, hydration, and daily oral antibiotics. But the gentamicin can be a little bit cumbersome. So there are companies that are working on basically a product that can be left inside the bladder and delivers antibiotics over a slow release over weeks to months.
Yeah, there's a similar devices being developed for bladder cancer that are slow release of chemotherapy or immunotherapy agents. So, yeah, that's an interesting mode of delivery that could hold some promise for these patients. Let's switch gears here, Javi. I want to talk a little bit about urodynamics and what's the role of urodynamics in the management of these patients. Maybe talk a little bit about video urodynamics, who are good candidates for that. And then if there's anything new maybe in the diagnostic space that you're excited about coming down the pipeline.
Yeah. In line with our AUA guidelines, there's a certain populations of patients that whenever they're newly diagnosed with X neurologic disease and that's leading to urinary dysfunction, that it's warranted, because we know that some of these patients can develop pretty high risk lower urinary tract phenotypes that may put their kidneys at risk in the future. So the people I'm referring to in this standpoint is anybody with a suprasacral spinal cord injury with any urinary dysfunction. Those folks should be getting video urodynamics. So, both the cystometrogram and voiding profile if they can, but in addition to having contrast in their bladder, shooting X-rays, looking for things like vesicoureteral reflux, looking for signatures of detrusor sphincter dyssynergia, things that would lead to practical changes in how we manage their bladder, either from a catheterization standpoint or from medication standpoint. And then that can include a lot of not just spinal cord injuries, but people with spinal lesions, either associated with demyelinating diseases, autoimmune diseases. A lot of folks can fall into that category. And then we have other folks who, either have cerebral lesions or anything suprapontine or like peripheral sacral nerve lesions, something like that, or folks who had nerve injuries from surgery. And these people need to be kind of risk assessed in terms of, okay, what are we seeing? Are they having any high risk features? Do they actually empty their bladder, or are they not emptying their bladder? For folks who are not emptying and you're kind of wondering, okay, what's going on from a storage and emptying standpoint, these are patients then where urodynamics is also valuable. Again, to kind of guide, all right, is your current manner of voiding safe? Like what you're doing on a day-to-day basis at home, is this going to be protective long-term? But there's a decent amount of patients that would fall under the category of, neurogenic bladder, neurogenic liver, urinary tract dysfunction, wherein just because they have a neurologic injury and some urinary symptoms, not necessarily all of them would need urodynamics. Say, for instance, had a stroke and are having some urinary symptoms but are emptying appropriately. Not necessarily all those people will need urodynamics in order to better clarify their treatment plan. But a lot of people who are having UTIs or any sort of concern for renal compromise, these people would benefit from that urodynamic assessment. It's an imperfect tool. There's a lot of variability, not just from day to day within a patient, but also from institution to institution in terms of how it's performed. Are they standing? Are they sitting? Are they laying down? Water charge, air charge catheters. There's a lot of variability. And so is it a perfect test? No. But when it's used appropriately in terms of trying to identify safety issues for patients, and also trying to use it as a tool to optimize their bladder management and keep them out of trouble in the future, it can be very useful.
Yeah, thanks, Javi. Anything that you'd like to add to that, Ann?
Yeah, I do a lot of video urodynamics with fluoroscopy and contrast, particularly in this patient population, because I'm endlessly surprised by the pathology that I find. And one of our fellows, Ann Suskind, helped me with a project where we looked at the question of, did the video add to your diagnostic ability? And in this population, it was a very high percentage of video urodynamics that actually changed management. It was on the tune of 30%. So in this patient population, I use it almost exclusively. In terms of who to do urodynamics on, Javi beat me to the punch. Those high-risk patients, they all need a baseline urodynamic study. And your patients who are avoiding, who are more low risk, so your brain lesion patients who are avoiding well, certainly don't need a safety study. They may need one to guide treatment. So, for example, your Parkinson's patient who has urinary retention and isn't emptying, although they're a lower risk neurologic injury, you have to figure out why they're in retention. So you do a urodynamic study. But your stroke patient who's emptying completely and their symptoms are resolved with some mirabegron, no, that person does not need a urodynamic study because you figured out clinically what was wrong with that person. But there are, especially spinal cord injured patients who have these occult, very dangerous bladders and have no symptoms. So terrible compliance, reflux, and they feel fine. And those are the patients that we really need to capture with urodynamics. And I think you'd asked as well if there was anything new in the diagnostic space with urodynamics. So actually just today, Bright Uro got FDA clearance for their intravesical, it's like a pretzel. It looks just like the chemotherapy delivery, but it's a urodynamic sensor that's placed in the bladder. So the patients are able to get their urodynamics in a much more physiologic setting with physiologic filling rather than being confined to the urodynamic suite. So I think that has some really interesting research possibilities and clinical implications. And I have no affiliation with them. I'm just very interested in their technology.
Yeah, hot off the press, Ann. That's great. So is that technically ambulatory urodynamics then? Is that sort of like outpatient urodynamics, or how does that work?
It could be used in that way, or it could be used in the clinic, just letting someone passively fill and do their urodynamics while they're hanging out. Fascinating.
Yeah, it's a really, really cool technology considering like in the future, whether that can be utilized as like some sort of like closed loop system where you can get data. You can imagine like something where you're getting data about, okay, this person's bladder pressures are starting to increase, they're having a spasm, and potentially some sort of delivery mechanism for either, like electrical current based treatment or something to that effect, that could be used in an ambulatory mode. It's pretty cool. I think, there's a lot of like future uses for that kind of technology.
Yeah, and the research applications of something like this, like let's say we come up with some new treatment for the bladder to reduce detrusor overactivity, do the treatment, put in the urodynamic sensor, and then study that person over the next 30 days. Absolutely fascinating possibility. So I'm pretty excited about that because it's really new and very interesting technology that works wirelessly. So the information gets transmitted real time to a Bluetooth device.
I like to, pay homage to our mentors. And you mentioned Ed McGuire earlier, Anne. What do you think? And he passed away recently, 2021, a few years back. What do you think he would think about this new urodynamics technology, and what was his impact on the field?
Oh, he'd be geeked. He'd be so excited. He loves urodynamics. He absolutely loved urodynamics. I learned to read urodynamics from him. He was masterful at reading them and came up with so many of the core concepts that guide our management of these patients. For example, leak point pressure. If your bladder storage pressure is over 40, you're in big trouble. And he came up with that intuitively. He didn't have 300 patients into a randomized control study. No, he came up with that intuitively by just looking at all of his patients at one time and saying, 40 centimeters seems to be right. And everyone's proved it to be correct over time. So he would love the new urodynamics technology. He was someone who was always very interested in exploring thoughtfully new technology, things that he thought were probably not a good idea because of their pathophysiology. Like, for example, excessive use of vaginal mesh. He never did that. He knew that was a bad idea from the get-go, so he never practiced with that. But things like midurethral slings that had long history of efficacy, he did perform those procedures. So he liked cool new stuff.
Yeah, Michigan has such a rich history in this sort of field, and you're carrying that legacy on, Anne. So kudos for that, and thanks for sharing some stories about Dr. McGuire, one of the true legends in urology. I wanted to shift gears a little bit here. Javi, maybe we'll shift in your direction towards surgery. We haven't talked a whole lot about surgery for the management of these patients. We've sort of alluded that some patients require surgery. There's obviously different surgical procedures, including interstim, Botox, augmentation. I think Anne mentioned augmentation earlier, potentially urinary diversion. How do you decide who needs surgery, Javi, and what are your sort of surgical approaches to managing these patients that require an operation?
Yeah, like broadly speaking, think about these folks in terms of whether we're trying to just optimize their day-to-day quality of life. Like, are we talking about this patient's just leaking a lot, the meds are not cutting it, and we're trying to just make things a little bit more manageable for them, versus the group of patients in whom you're like, okay, they are in and out of the hospital with severe infections, where they're blowing out their kidneys. Those people are in a separate group. And oftentimes those are the people who are kind of below and past the more conservative management, or at least the lesser invasive of the surgical options. But for those people who, since you mentioned like Botox, for those patients in whom, say, we've done urodynamics, we kind of understand that their bladder is under higher pressure while it's trying to store. We're trying to achieve a better storage environment, and perhaps by that also decreasing their leaking. Botox has a great role in that. Is well tested in the neurogenic population. Like I mentioned earlier, this is another situation where you do have to be cautious in terms of the spontaneous voiders versus the people that are using catheter-based care. Those spontaneous voiders can be tipped, even more so than in the non-neurogenic population, into retention with Botox use, but there's still a role for some of those people. The patients I think about in that context are like patients with MS who maybe are not necessarily these terribly progressive disease patterns, but more so people who are like still ambulatory, voiding spontaneously, but they're not emptying all the way and they're leaking. We know they have some detrusor overactivity. those patients that do like to be a little careful about using Botox. You mentioned InterStim also. There's some select patients within the neurogenic population in whom that can be helpful and in whom neuromodulation can be helpful in general. I would say also that specific population I just mentioned of like the ambulatory multiple sclerosis patient who's still kind of voiding on their own. That can be a great population for InterStim. That may be something that lasts for a period of time. Maybe if their disease progresses, it will no longer be as efficacious, but can potentially help them to at least have a period of time where their symptoms are greatly improved. There's other patients that neuromodulation procedures like InterStim or signal neuromodulation in general can be helpful. There's not a ton of data out there. We're talking about like mostly small series of patients, but people with Parkinson's, there's some data suggests that's helpful. A little bit in stroke. Our AOA guidelines suggest not using it in the spinal cord injury population kind of at large, although there has been some small studies done that have shown some benefit. These are very selective patients in whom it's feasible and reasonable. I mean, thankfully, we're at a stage now where those kind of neuromodulation devices are MRI compatible, and so that was more of a historical problem where that was just a no-go for using it in those folks. But now, thankfully, they can still continue to get their MRIs when they need them and also have this device to help them. Botox also can be, just to kind of go back to the safety issue people, Botox can also be used in those folks for sure in terms of a trial to see like, okay, we know that your bladder is getting a little bit more hostile and we need to do something to curb the progression of this. Botox can be very helpful in these people. In terms of, dosing, I mean, the people who are using more catheter-based management, a lot of folks, maximize the dosing to up to like 300 units. And so that can be helpful to really try and improve their storage. But even so, some patients are just that's not going to cut it for them anyway. And those are the people in whom I think, then we start to steer more towards, okay, you need something a little bit more substantial in order to keep you out of trouble. And then in terms of what kind of surgery is reasonable, there's a lot of different considerations that go into that for sure. The bladder augmentations with or without channels, they require a lot of work from the patient side. And so knowing the patient's social situation, like can they catheterize themselves? And if they can't because of either limited dysarthria or no hand function or upper extremity function, do they have somebody at home that's going to be able to reliably do that for them? Those are major considerations in terms of like, is this actually a sustainable solution for their problem? Knowing that they're going to need to have very strict regimens for catheterization, for irrigation. I think like particularly for some of the younger patients in whom maybe avoiding stomas is really important. Like they're at a point in their lives where, either for social reasons or just because that's just how they envision their life, don't want to live with a stoma. Augmentations, channels, those can be really valuable solutions for them to maintain continence, but also to lower those pressures, protect their kidneys, and stay out of the hospital. But ultimately, there's some patients in whom that's just not a reasonable solution because they won't be able to do some of that care, or they don't necessarily want to be doing some of that care. And then those are folks in which some of the more the like incontinent sort of surgeries, either talk about ileovesicostomies, cystectomies, conduits, pouches, I'm talking incontinent diversions, but doing urinary diversions, the conduits or something of the sort, or colon conduits, if that's indicated, can be really helpful to both simultaneously protect them, but also make it so that we're not just overcomplicating their lives with the surgery that we do.
Yeah, thanks, Javi. I think Javi covered surgery pretty well, but anything you'd like to add to that, Anne? I know there's a lot of different options, and obviously you want to tailor the surgery to each individual, but anything that you'd like to highlight, Anne?
Yeah, the Botox, I go to that very quickly in the management of patients. Unlike with other conditions like overactive bladder, where insurance mandates that people try multiple medications, even though the new OAB guideline doesn't say that that's necessarily helpful. A patient fails one medication, they're still wet. I think that's a life-altering and potentially health-threatening condition because of the skin deterioration, social isolation, depression, lack of intimacy that's associated with incontinence. So I go to Botox very quickly. But the other thing to remember is that Botox doesn't always solve the problem, and people are getting stuck in this Botox loop. Well, just one more dose, let's see how this goes, and are very hesitant to proceed to augment, whereas 15 years ago, we did augments all the time because we really didn't have access to Botox, and so that was your next step. So I try not to let people get stuck in a 300 unit of Botox every 3 months routine that's not working for them, because augmentation cystoplasty patients, they are the happiest people. There is data to support this. The Enbridge group, led by John Stoffel, did a very in-depth quality of life assessment of patients with neurogenic bladder, and they focused on spinal cord injury. And your reconstructed patients, by far the happiest. There was not even, it was leagues of difference. And that's because an augmentation cystoplasty gets you a reliable 800 cc bladder. And you know what that lets you do? Sleep through the night. That's awesome. Sleeping through the night is epic. If you have a really small bladder capacity, say you're getting up 2-3 times a night to cath, and maybe you need to transfer to your wheelchair, or maybe your spouse has to catheterize you in the middle of the night because you have a hard time laying down to cath, it can be so life-altering. And particularly female patients who don't have very good urethral access, because unless you have good trunk function, you can't catheterize your own urethra because you usually need to transfer to the toilet as a female patient. Giving them a cath channel and an augment all of a sudden makes them in charge of their bladder. They can catheterize wherever they want. They don't need to lay down flat to catheterize, because you can't leave your house if you have to lay flat to catheterize. So people are like laying flat in the back of their car at the mall trying to catheterize themselves because they make baby change tables, but they don't make places for people with disabilities to do their bladder management. So right now we're having to work around that. But a patient with a cath channel can cath on an airplane, in the airplane seat, and it is not a big deal because they're just exposing their umbilicus. So I meet a lot of women whose bladders are safe and they're not dangerous, but they can't live with it as is because they're dependent on other people, which, that's really sad. So if you can help those people gain independence and good bladder functioning, they are so happy to be able to take control back of their lower urinary tract.
Yep, that's great. Give them their independence. Go to Botox early, but don't persist in Botox purgatory.
Exactly.
Yeah.
All right. Well, this has been great. I have one more question, and this is kind of a sort of a dreamer's question. So I'll start with Javi first on this, but I'm curious to hear what Ann has to say as well. So Javi, if you had unlimited resources, what would you do to improve the management of patients with neurogenic bladder?
Yeah, there's certainly a lot that could be done to help this population. The first thing that comes to mind, just because it's something I've been thinking about a lot lately, to do trials for neurogenic bladder patients using some of the neuromodulation technologies that are continuing to come out over the past years, and data is emerging in the overactive bladder population. For example, like some of these implantable tibial nerve stimulators, and there is data that exists in terms of showing efficacy in various neurogenic patients that percutaneous tibial nerve stimulation can provide some benefit, and that goes back to Ed McGuire as well. I guess the first person to really demonstrate this, I think, in like spinal cord injury primate models decades ago, and that continues to evolve. There's various different companies coming out with data, but the focus is on overactive bladder reasonably, and it's tough to recruit for this kind of population. But I think establishing whether there's good efficacy and good indication would be really great. There's a lot of patients in this group in whom a sacral nerve stimulator is not going to be feasible, or is not necessarily safe to do for various reasons, and I think there's a lot of room for potentially using for those and for these folks. You can look how it's used in terms of sacral neuromodulation, but that wasn't the main reason it was brought about. But we know that it does work for certain neurogenic patients, and so that would be perhaps where I would apply the money.
That's good. And what about you, Ann? Same question. Dream big.
Yeah, I mean, my pie in the sky for this patient population would be much more advanced neuromodulation than what we have now. The primary problem that this patient population have is a neurological one. The hardwiring is not functioning and their bladder is denervated. If there was a way of re-innervating their bladder and not just stimulating the bladder to contract because they're going to have a closed outlet, which is dangerous, but finding some way of coordinating bladder contraction, sphincter relaxation on demand, so a patient can do it at the right time when it's convenient for them, but also having some kind of sensing technology, which we alluded to earlier. So finding a way for a patient to be able to sense when they're full and for a patient to be able to activate voiding with a coordinated void at the same time. And I think we are within reach of that. This is not all science fiction. I think we possess the technology to do every one of the things I just said, but actualizing it and doing it without causing harm, because the Brinley stimulator, which existed in the past, required a pretty significant rhizotomy that eliminated any bladder neurologic innervation you had. So if you're able to do this without causing harm, I think that's where we're headed. And I think finding some way of preventing urinary tract infections would be epic. And if you can achieve physiologic voiding, there you've solved both of the big problems that this patient population has: incontinence, retention, and infections.
Yeah, that's well said. And I am so thankful to have Ann Cameron and Javier Santiago working on these pie in the sky ideas, because I think they're going to make a huge difference in the lives of these patients. It's clear they're passionate about this topic. We've unfortunately run out of time, but I want to thank our guests. Ann, thank you so much.
Hey, you're welcome. Thank you.
And Javi, thank you.
Thank you, Kyle. It's a great pleasure.
This has been great. You guys are fantastic urologists and clearly experts in the field. We had a great discussion this evening on WInnovations, talking about neurogenic bladder, nuances, new approaches, and next level. And I want to thank all of our listeners out there, as well as our producer and editor, Sandra Miller, and the chair of our department, Dr. Steve Nakata. And thank you all for tuning in. So long.
WInnovations is a production from the Department of Urology at the University of Wisconsin-Madison School of Medicine and Public Health. Thanks for listening.